Thank you all very much for the kind invitation and for that welcoming comments. Again, Jay, I'm sorry I'm not with you in person, but I'm eager to be a part of this very important time. You got Mickey on the agenda, so you're going to hear a lot about what we can do to move forward. I'm going to do my best to kind of connect a few dots on where I see the opportunities to bring new ideas to life. I think we provocatively titled today's discussion on whether innovation is a buzzword or an opportunity for action. I think the answer is pretty clear. We need a lot of change in the system, and that change is going to take place if we get the raw materials right. If we can open up more data and if we can share that information and use it to advance the care delivery system, rewarding those who are successful at delivering higher quality care. Earlier today, I was on the phone with a large academic medical center, and a physician was sharing a program she had launched to help address rural access issues for diabetics that were at risk of losing, some of their ability to manage their condition. And she was lamenting that her current compensation model, which is an RVU based model, wouldn't care a lick if she's able to get folks to be managing their A1Cs to meet those quality scores. That's not graded in the comp model. And we have a system that people want to do the right thing, and sometimes that right thing isn't rewarded. So you're going to hear answers today on this important question if we can solve these underlying issues. So let's dive right in and get a little bit of a walkthrough on history. We've been a decade at this open data revolution, and I want to take stock about where we are. Many of you were part of the family back when I was in Virginia government, and we were home to some of the national HIEs that were tested. 2 of the 4 were in Virginia before I went into the Obama administration, and there was a lot of lessons learned. We've been kind of taking stock, if you will, on the migration from the traditional data sharing models that have been in place in healthcare over this past decade, moving it through networks to moving towards this more modernized application-based approach to sharing data. And sort of that hope is that when we finish my remarks today, there'll be some momentum amongst the eHealth Exchange family to dig into that TEFCA, hopefully that FHIR roadmap in TEFCA, so we can marry some of the modernization technologies with APIs with some of the benefits of network infrastructure on regulatory and technical and business model innovations. So where are we? We've got bedrock rights. Consumers have the right to access their health information from EHR systems, providers, and government-sponsored plans. And if you're lucky enough to be in the great state of California where you are all today, by 1/1/24, all commercial plans have to offer that same, call it blue button right. It's very exciting. Congress has doubled down on consumerism. They've now given consumers the right to request prices. And expected in that response is a perception of the quality of care one would get when identifying a provider that would be suitable for the care that they're looking for. So consumerism is at the bedrock. And I heard Jay at the beginning of my remarks talk a bit about the individual access service. I think it'd be phenomenal for us to make material progress on honoring those rights through the networks. Second is the clinicians' rights. This is new thanks to the Cures Act, and I'm grateful for it. In addition to the consumer API, the Cures Act has given us 2 additional APIs. And for the purposes of a clinician looking at operability, forget the interoperability piece. A clinician looking to download an app to help the clinician be more effective and efficient in care, that now is enabled by this new right, the right to install a third-party Smart on Fire app within the EHR, the right to get from the hospital an admissions, discharge, and transfer feed when a patient you're caring for ends up in the hospital, and the right, thanks to the QHINs that are going to come online soon, to be able to tap into the national networks as a physician for treatment purposes, to be able to pull in patient historical data. So we've got the consumer's rights, we've got the clinician's rights, and now we've got the technical capacity to share data with partners we trust. That could be a clinical registry, maybe the American College of Cardiology's registries I used to work with back in the day. In Virginia, we did a pilot with outpatient cardiology work. Could be a payer or a neighboring ACO for the purposes of quality performance improvement. Whatever the case may be, these three capabilities, consumer, physician, and the ability to share with partners through bulk FHIR, these are all core technical rights, a decade in the making. Very proud that we've made this progress. I'm also grateful that ONC has funded the Inferno program, a test suite to make sure that the servers that are out in the real world actually conform to the specifications so we can actually get the data flowing at a high quality. You'll note that Apple Health requires all providers to be seen on the Apple network to go through a conformance testing step, which is not required of any other app. And I'm grateful that Apple has compelled the industry to do that because they've identified organizations that have had maybe poorly developed systems, and it's kind of given feedback to the EHRs to fix it so that they can be displayed for their patients. The open data piece is not just about the interoperability sharing, but it's also about the raw data that's been made available. Many of you may be familiar with CMS's decision to release Medicare data into the public. As soon as CMS made that policy change, 2013, 2014, you could go onto the internet on, this is the Wall Street Journal, Medicare Unmasked, and they did a one-time summary of all the physicians that were in the database. And so if you ask the question, who was the highest paid doctor in the CMS database in 2015, that was Dr. Derek Kunimoto, an ophthalmologist who got a whopping $11.1 million thanks to Medicare. Now, that may be a lot of physician visits. You may be wondering, how did that happen? And so it turns out that Dr. Kunimoto, like many of his retinal specialist friends, injects a drug to stall the risk of blindness. There's a $50 version of that drug. There's a $2,500 version of that drug, and there's a $3,500 version of that drug. And you can see, relatively speaking, Dr. Kunimoto errs on the side of using the higher cost drugs when caring for the patient. Research has shown that they're all clinically equivalent, by the way, so it's a bit of a spicy topic on value-based care. So the good news here is that we've got a pretty solid foundation on which to build this next decade. And to kind of remind us a little bit of what I said earlier on the physician's rights, Apple Health, back to speaking to that idea of third-party apps, physicians in certain EHRs can download the Apple Health app so patients can share their steps and other Apple Watch outputs to be appearing natively in the EHR through a third-party app. No fee to the doctor, no fee to the patient, no fee to the Apple. You have the rights to ADT feeds, as I mentioned earlier. Some organizations are using cloud tools to help facilitate that ADT feed transfer. And you could reference any service or app, but I've highlighted big tech in this presentation, being able to query the networks and then organize the information so you can kind of identify the key indicators that come out of it. You know, we've been at this CCD sharing now for a little while, and I don't know how many doctors appreciate reading 30, 40 pages of a CCD. And so being able to have a computational access so that you can kind of filter on the most important and salient issues, I think is a big part of this innovation story. The reminder on the partnership side, Jay has been very gracious of working together on this idea of a TEFCA FHIR pilot powered by bulk FHIR. A reminder, the Cures Act did require that bulk FHIR capability is a certified component. It's the G10 certification criteria. The vast majority of EHRs, I think 270 plus at last count, have certified that they've been able to ship that technology to their customers. All customers of EHRs had to turn it on by October 1, so end of September. No clue how many people have done that. I would imagine not as many as we would have liked, but a reminder that that is what is part of the MIPS ACO kind of quality requirement. So hopefully we'll get more organizations to go live before the end of the year. But mostly what I'm keen on is making sure that we start testing this infrastructure. And so the dream is that eHealth Exchange in this community can start to put together test cases of what it would mean to enable this sort of sharing. So building on the announcements earlier this year with Mickey and Marianne on TEFCA, which included the TEFCA Fire Roadmap, I thought I would zoom in on the stage 2 of the TEFCA Fire Roadmap. It was called the Network Facilitated Fire Exchange. That essentially is a facilitation of point-to-point sharing. So a provider or a payer agreeing to share access to a population that each of them are entitled to see, and to enable that through the sharing of each other's bulk fire contract. And ideally, eHealth Exchange could enable that query within those limited populations. My hope is that we'll start to see in calendar year 2024 in production real-world experiments to demonstrate the art of the possible. 2 public initiatives that have been announced already. 1, NCQA is recruiting payers and providers to voluntarily participate in a bulk fire data quality coalition. The goal is to test whether or not we can run the HEDIS quality measurement engine by basically merging a patient's claims history and EHR data, and the marriage of those two enabling us to do something akin to calculations of the key quality measures that NCQA has already shipped in a native kind of fire format. By the way, NCQA is committed to open sourcing the engine that would allow for the calculation of these measures. And so hopefully over time, this will start to democratize quality measurement so we can run it every single day and not wait for the reporting periods after the fact. Secondly, the VA has announced an interoperability pledge. 13 health systems. I hope some of you are in the room today at the Health Exchange Conference, are capable of sharing or committing to sharing information bidirectionally with the VA. So starting with the obvious point, can I see veterans in my database as a health system? If so, can I alert the VA when one of those veterans shows up in my institution? And could the VA communicate back to me critical information like eligibility criteria for certain benefits tied to that veteran's care? And obviously closing that feedback loop to ensure continuity of care, to share back the clinical encounter summary into the eHealth Exchange, or ideally through the eHealth Exchange back to the VA for purposes of quality measurement and care coordination. So my hope is those of you in this room can spend some time thinking through how to launch a bulk fire network mapped to the TEFCA Fire Roadmap that was announced earlier this year. That's a mouthful, but I know you can do it. Now, I have to acknowledge that this innovation buzzword or action, does speak to the incentives in the system. And so we did aspire back in 2009. This is the transition team memo before I joined the administration. Myself, Farzad Mostashari, Todd Park, physician, Dr. Peter Bash from MedStar, who chose not to come into the government, and my eventual deputy CTO, Danny Weitzner, MIT professor, we penned a kind of a letter to Dr. Blumenthal, then the ONC director, and said, please, let's make meaningful use meaningful, and let's emphasize key population health goals, namely the Million Hearts Initiative as one example, but others were suggested to get us thinking about the ways in which digitization in service of a clinical outcome and hopefully rewarded by a healthcare system could give us that virtuous cycle for innovation fuel. That unfortunately never landed. One of those frustrations for me is that the demand signal for value-based care amongst the technology leaders in this country did not materialize. The demand signal was mostly government mandating and not so much market pull. And so what we find ourselves is a decade later, when asked by the National Association of ACOs, these sort of value-based care networks, many of whom you all operate in your given health systems, the majority said that they are not ready to move to a digital quality measurement framework by 2025, which is the policy mandate. And they have to spend $500,000 a year or more on custom IT because they've not figured out how to do the interoperability parts well. Most of these networks have more than 6 EHRs in the network. And so it is a challenge to put these pieces together. I want to remind everybody that US CDI is the floor, not the ceiling. We don't have to aspire to the minimum. We can do more. And I'm grateful that CMS has pushed us. So for those of you who've been following the Cancer Moonshot, obviously an initiative very deep and personal to President Biden, also to President Obama, but the Cancer Moonshot launched in the Obama administration and carried forward to this day. They've now introduced an option for cancer centers to use a FHIR-based approach to report the dozen or so clinical data elements tied to a person's cancer care. It's shocking to me in 2023 that cancer stage is not part of the US CDI, and we have to close that gap. My sense is that we can do a lot more together if we are getting a coalition of the willing to step up and offer to do more than what is minimally required in the regulatory process. So that's an area where we can adopt a kind of an aspirational goal. Also, smart health brands. I love this simple idea. How will consumers find our FHIR endpoints? A lot of discussions about endpoint directories, and Jay, I'm sure the eHealth Exchange team's going to do a wonderful job. But while that's useful in a B2B context, I would love for us to embrace the Smart on FHIR standard so that we can more easily communicate these FHIR endpoints, mapping a physician to a FHIR server or a health system to the app developers. So Apple, Common Health, the stakeholders who want to route patients to the right endpoints to get their medical records. It's possible. And the innovation fuel will come if we can get the incentives right and we can open up these pipes so that the information can be fuel for some of these capabilities. Perhaps the last and most important ingredient on the innovation question is whether or not we can make more actionable the ability for computers we designate to access information that we otherwise have to manually access. Health plans have been faxing doctors every day for many years, lists of care gaps. I don't know what most physicians do with that information. Do they staple it to the patient's chart? Do they deal with it in a daily huddle? I have no idea. But to me, the opportunity is to focus on programmatic access or computational access to the source data. And so CMS is the first out of the gate. They've launched their physician-facing FHIR API, accessing claims history. It's called the Beneficiary Claims Data API, or BCDA. And earlier this summer, in May, they released a partially adjudicated version that gives much more timely access to information. Today, many of you that operate ACOs that bring in the claims data for computational access, you get them 6 to 8 weeks after the fact, and it's hard to take clinical action on information that wasn't available to you right away. Now with the partially adjudicated API, within 10 days, you can get a majority of the activity from the data visit. So you can actually engage patients to ensure that they are getting the kind of coordinated care that they deserve. So I'm grateful that that'll be fuel. And by regulation, all government-sponsored plans will have to offer this daily FHIR API by 1/1/26 as proposed. But it also means that we can interact with the back-end systems for prior authorization. So who knew CMS allows doctors to prescribe Botox for migraines? So a physician that asks the question, can I use Botox for migraines, can get the immediate yes, no. And here the answer is yes. Using AI, they're able to simplify all the steps you need to do to demonstrate that the patient is in clinical need for this purpose. And so this is the next chapter of innovation, is to be kind of driving towards value. Some might think of this as innovation that's deflationary in healthcare, not innovation that's inflationary. And that's really the main objective in my remarks today, is to emphasize, yes, we're poised for innovation, but the action we're hoping to be poised for is a deflationary model where the innovation helps the systems deliver higher quality care at lower possible cost. What I thought I might do is just sort of wrap in the last few minutes that we can talk through the generative AI opportunity. And what I want to describe for you now is a little bit more about the art of the possible, uh, in part because I think we're going to find ourselves increasingly asking my AI designated app to interact with your interoperability platform to be able to perform a function. Now, let me just walk you through Dr. Peter Lee's example. I refer to this as the era of health information fiduciaries. That is to say, applications and services that are designed, as President Obama said, to safely and accurately analyze my health information. President Obama spoke of this at the launch of the Precision Medicine Initiative back in 2015. But the principles hold. There's no obligation today in the regulatory process that app developers build a fiduciary. But I believe we can call to action app developers to voluntarily adopt a code that makes sure we're operating in the patient's best interests. The architecture of this innovation platform is a lot closer to what Peter's co-author, Dr. Zach Kohane, said in their revolutionary book on AI and healthcare that was released earlier this year, a must-read for those of you who are interested. Dr. Kohane said in 1994, in a proposal to DARPA that they did not fund, sadly, that, quote, we propose a major shift of focus away from information systems based on the hospital or the clinic or medical practice to one that's based on the individual. Such a system we will call a guardian angel. That is an ultimate information fiduciary, authorized to tap into all the source systems, to connect through your networks, to be able to pull our loved ones' records together, and to apply some of these new capabilities to help us understand the next step in our healthcare journey. Peter is relatively healthy. He shared publicly a task he gave to a private version of GPT-4 earlier this year. And he noted that his recent lab results were uploaded, and he asked the question, can you explain in simple terms if there is anything I need to be concerned about? To which the GPT responded, these values suggest that you may have some form of anemia or iron overload disorder, obviously with appropriate caveats that you should consult your doctor for further evaluation. This is the beginning. If we get the incentives right, if we opened up the underlying data to know where and how to get the best quality care, and we open up the pipes so that the physicians we trust to care for us have all the information they need to do their jobs well, we can unleash this innovation engine. And as I believe in a value-oriented world, that innovation engine will likely bring down healthcare costs and improve quality, not necessarily be an expansive innovation, which has been the case for healthcare going back 20, 30 years. I'm hopeful that the eHealth Exchange community can take an active role in making sure we can make these regulations and policies real. As many of you can imagine, while we have these G10 certified fire servers in the community, unless we act through the eHealth Exchange, it's not clear to me where and when those services are going to be deployed. How will we fuel innovative applications that advance quality and lower cost if there isn't access to the underlying information available to me to read as a human or my designated AI to interpret safely and securely? My hope is that we will leave today's session with a clear call to action, that we can build these TEFCA Fire roadmap pilots. We can implement the plan that Mickey will inspire you to say if he hasn't already done it, and that we can execute with great confidence that this water is warm, that we can tap these regulated endpoints and make that information flow safely and securely. If not eHealth Exchange, then who? No pressure, but we're counting on you to help unleash this innovation revolution by opening up these pipes. I want to thank you so much for your time, and I'm eager to follow up on any next steps, especially if those of you want to raise your hands and participate in some call to action. Jay, I'm counting on you to recruit those participants and to gather those names so that we can work together whether it be in service of the NCQA project, the VA project, or several unnamed projects that can focus on advancing the ball. Thank you all for having me. Again, my apologies for missing you in person, but I wish you the very best for the rest of the conference.